Good afternoon, dear esteemed professor and colleagues attending today's conference. My name is Trần Nguyễn Khánh Chi from Hanoi Medical University Hospital. I would like to present a report on the topic, value of intranodal dynamic magnetic resonance lymphangiography in identifying anatomy and diagnosing thoracic duct leakage. My presentation consists of 4 sections. Regarding the overview of the lymphatic system, it includes the central lymphatic system and peripheral lymphatic system. When damage to the central lymphatic system, it can lead to chyle leakage, while damage to the peripheral system can lead to lymph leakage. About the anatomy of the thoracic duct, it is the largest lymphatic vessel in the body. It consists of 3 segments, abdominal, thoracic, and cervical, with the thoracic segment being the longest. Thoracic duct exhibit numerous anatomical variations. There are 6 main variations. First is complete left side of the thoracic duct. With this variant, we must be careful when approaching the cisternal chyli due to it is too close to the aorta. The second is right side complete of the thoracic duct. This can be considered as a normal anatomy. The next is proximal and distal partial duplication of the thoracic duct. With this variant, we may accept both brains to find the location of leakage. Next is plexiform variation of the thoracic duct. It is challenging when intervention due to its small and tortuous branches. And the final is absence of the cisternal chyli. It presents difficulties in approaching the thoracic duct. In such a case, we have to access via intestinal or lumbar trunk. The function of the thoracic duct is transportation of the chyle from digestive system to the central circulation. It can carry up 4 liters per day. Chyle contains many important components such as triglyceride, chylomicron, vitamin, albumin, or electrolytes. This is a table help us distinguish chyle and lymph fluid. Chyle is characterized by a milky appearance with a triglyceride concentration above 110 milligrams per deciliter. And the gold standard test is lipoprotein electrophoresis chylomicron in the fluid. Thoracic duct leakage is a rare condition. It can categorize into 2 main groups of causes. Traumal causes, including surgery, intervention, or radiation therapy. And the other group is non-traumatic causes, including malignancies, congenital, infectious, or idiopathic. As I mentioned before, chyle contains many important components, so prolonged chyle leakage can lead to numerous complications such as immunosuppression, malnutrition, respiratory failure, or even death. Some reports indicate that the mortality rate due to thoracic duct leakage after esophagectomy can reach up to 50% if not treated. Additionally, chyle leakage through the surgical wound with the disruption of the normal tissue biochemistry lead to delayed wound healing and infection. Diagnosis the location of thoracic duct based on imaging technique. Previous methods are lymphoscintigraphy, pedolymphasiography, and intranodal lymphasiography, but these methods are less commonly used to diagnose the leakage location due to radiation exposure and time consumption. Dynamic magnetic resonance lymphasiography is a minimally invasive method, provide good anatomical and dynamic assessment, as well as detect lesion. Our study includes 42 patients with chyle leakage who visited our hospital. The selection criteria are patients with child leakage are diagnosed both clinically and laboratory tests, and they underwent MRI and DSA of the lymphatic system. This is the research method. The most important equipment of this technique is an MRI machine with a movable table that retaining the scanning room. This image shows preparation equipment and patient for this technique. We insert the needle into the bilateral groin lymph node. This is the dynamic MR lymphadography protocol at my hospital. We use T1 weighted 3-dimensional level sequence before and after injection contrast and performing in both axial and coronal plane until the entire thoracic duct is fully imaged. About the results obtained. Regarding the general characteristic, the average age of 42 patients is 15, and there are 26 females and 16 males. About the causes of thoracic leakage, 35 cases were due to trauma. With this patient underwent surgery, and the remaining 7 patients had non-traumatic causes, primarily idiopathic. Among the type of surgery that's got thoracic duct leakage, half of the patients in this study underwent thyroidectomy with 18 patients. According to Roth in 2008, the incidence of thoracic duct leakage after thyroidectomy can range up to 5 to 8%. The next most common cause are esophagectomy and lung or lobectomy resection. It is aligned with the finding of Maximilian in 2010. Regarding the anatomical correlation between MRI and DSA, both methods show a very good correlation about normal anatomy, complete left side thoracic duct, and absence of the cisterna chyli. For other variants, both methods also show a good correlation. These are anatomical variants of thoracic duct on MRI and DSA. Figure A shows a patient with proximal partial duplication, and it is similar on DSA. Figure B shows a patient with a plexiform variation, and Figure C shows a patient with complete left side thoracic duct, and both of cases are entirely confirmed on DSA. About the location of thoracic damage, we observed that the highest incidence of thoracic duct location leakage are cervical and thoracic segment, with 19 and 16 patients respectively. It is aligned with the finding of Maximilian in 2012. About the ability to detect brain duct lesion on MRI DSA, MRI detected 8 cases, while DSA detected 11 cases. MRI has a sensitivity of 73% and a specificity of 100%. Figure A shows a patient with brain duct lesion creating a fluid collection on the left supraclavicular region. And Figure B shows a patient with direct contrast leakage from thoracic duct into the mediastinum. Regarding the detection capability of fissure on MRI and DSA, MRI detected 35 cases and DSA detected 38 cases. The sensitivity of MRI is 92% and specificity is 100%. The study of Lee and his colleague in 2018 also reports that MRI and DSA are similar detection capability on finding the location of leakage. These are morphology of thoracic duct injury in them on MRI and DSA. Figure A is contrast leakage. Figure B is personal aneurysm, and figure C is brain duct injury. These images have been similar confirmed on DSA. Based on the research results, we draw the following conclusion. In anatomical assessment, DSA MRI show a good to very good correlation with the detection ability of MRI and DSA for leakage compared to DSA has a sensitivity of 92% and a specificity of 100%. Dynamic MRI lymphatiography is minimally invasive method with a shorter execution time, no radiation exposure, and provide good anatomic and evolution of thoracic duct injury. This is truly effective in planning interventions and treatments for patients. That's all of my presentation. Thanks for your listening.